Okay. Hello, everyone. This is Ali, one of the pediatric residents. Today we'll be talking about one of the interesting topics that I like. It's going to be talking about fever. So fever is one of the common complaint in pediatrics. So we'll be talking about fevers in pediatrics in general. And because it's going to be a very long lecture, we're going to talk about it divide it into 4 lectures. Okay, so we'll talk about fever in well-appearing children, which is a guidelines that the AAP produced around 2001, and then this month the Peds Interview also published an overview of it in 2023. And then we'll talk about early onset sepsis and late onset sepsis in the second part of the lectures, and then we'll talk about fever without a source, or fever without focus, or fever of unknown origin, which is completely different ones, in the third part of the lectures. And the last one, we'll talk about fever phobia, which is an interesting topic there is. So usually this is going to be the first lecture, second lecture, third, and fourth. So it's going to be four-part topic, which is an interesting one. It's a very common one that you will all go through. So first one we'll talk about is the fever and management in a well-appearing child. So basically, there's a big guidelines that was published under the title of Evaluation and Management of Well-Appearing Febrile Infants within the age group of 8 to 60 days old. And basically, here, what they were talking about is there's a certain criteria for it. So they said, give me a sec, technical issues. Okay, so what was the inclusion criteria for this topic, right, or for these guidelines? So basically they mentioned, okay, so it has to be a well-appearing child, and then they said they have to be in a well-appearing patient by an attending physician, because they wanted to base it based on someone who has the experience and exposure to multiple patients that can have the comfortable judgment to say, with the good risk tolerance and stratification, to say this is a well-appearing child. And then they said these patients have to be term infants, whether they are 37 weeks and above or below 42 weeks. They have to be previously healthy. And by the definition, a previously healthy patient is basically a patient that does not have any suspected immunocompromise, it does not have any major congenital or genetic abnormalities, and there's no previous surgeries that happen or treated infections, or if there was not a medically significant perinatal course. And then they said these patients need to be between the age of 8 to 60 days of age, at home after being discharged from either the newborn nursery or born at home. Some sources said they need to have a rectal temperature, because it's the most specific and accurate measurement of fever in infants, to be 38 Celsius or 100.4, and some said as long as you have a confirmed fever of 38 or 100.4, then we have it. Then when they classified it, they classify it based on age groups. So they said we're going to divide it based on age group: 8 to 21 days of age, 22 to 20 days of age, and 29 to 60 days of age. So basically 1 week to 3 weeks of age, then finish that 4th week of life, and then basically the second month of life. And they did an inclusion and exclusion. So this was what the inclusion criteria is. They said it might be included, which we'll discuss at the very end for a specific reason that I wanted to mention, but I'll just mention it right now for a quick reason. They also said it may be included to have these patients with upper respiratory tract infections, these patients that have diarrhea, unless there's a highly concern for bacterial pathogen, recent antibiotic use in infants more than 2 weeks of age, which is fine, positive viral testing, and otitis media. These criteria can be included. And then they said, okay, we're going to exclude any infant below 7 days of age, right? And then any infant above 60 days of age. If he's not well appearing by attending, then it's not included in this. Cannot be applied. The regulations, if there's a high concern for herpes virus, if there's a focal bacterial infection that you're suspecting, if there's a clinically proven bronchiolitis, if there's any immunization within the past 48 hours, medically fragile chromosomal abnormalities. As we mentioned, this is a not previously healthy infant. And then suspected immunocompromise if less than 2 weeks of age and perinatal course with maternal fevers. So basically anything outside of the criteria that we just mentioned. So a quick background on everything. So here, they said in 1970s, GPS infections, the group B beta streptococcus infections, has been on a rising infection. In the 80s, they started to highlight there's a lot of iatrogenic complications from when they're treating the patients with antimicrobials, hospitalizations, or interventions that we were doing. And then between the 80s and the 90s, they said, okay, we're going to validate clinical predictions models to detect serious bacterial infections. And they touch base on whether it's cellulitis, pneumonia, gastroenteritis, by bacterial infection, UTIs, or meningitis. And they said there's a high sensitivity around 95%, but there is a negative predicting value of 97 to 99 and low positive predicting value around 40%. In the mid-80s, they said, okay, we cannot really predict the high-risk groups. So let's make a criteria for the low-risk groups and based on it go from there. So if there's a patient that came in less than 20 days of age and has a fever, just hospitalize the patient. If that patient came in with a fever and he was 29 to about 90 days of age, okay, let's give him intramuscular ceftriaxone, do an outpatient follow-up, and check cultures, blood cultures, urine cultures, CSF cultures, and go from there. So present day consideration that we found that there's a big change in the bacteriology that's occurring right now. That being said, there's prenatal GPS screening right now. There's increased vaccinations for the pneumococcus infection. There's the food safety and regulations for listeria. And then E. coli became the most common cause of bacterial infections. And the second most common cause of meningitis infections in 1 year of 1 day to 60 days of life. And then the shift in the predominance of the infections from the gram negative to the gram positive bacteria. There's a consideration that they were talking about, which is safely do less. We have a lot of resources that we have, and we can overuse them, as you will most commonly see, or we can make sure, based on clinical judgment, how can we effectively use the resources that we have without increasing the financial burden on the medical system and on the patients and the parents. So financial and social cost, hospital-acquired infection, iatrogenicity, and prolonged hospitalization stay, these are all considerations that they wanted to go through. And now we have more and more adequate inflammatory markers. So in the past, we relied on the WBCs, on the bandemia, and the absolute neutrophil counts. But now we have the CRPs and the procalcitonin. We have for infectious disease, we had those automated blood cultures, which are very interesting to know how they work, which can detect infections within the first 24 hours. And they said we have that multiplex PCR, which can give you a results on the biovirus for less than 1 hour, or the multiplex on the meningitis panel within an hour. So we have so much improvements in our advanced testing nowadays. And then there's lots and lots of opportunities to improve hospitalization care. And then lastly, which is one of the core principles of medicine, is evolving and improving the research strategies that we are going to do. So first criteria, as we mentioned, was this classification of age group from 8 days to 21 days. So again, this patient has to be a well-appearing patient. These patients have no evidence of source of infections. It has to be a temperature of more than 38. Alright, so if an infant came to you after 7 days of life, because when we discuss early onset sepsis and late onset sepsis, it's within that 7 days. We have that 8 to 21 days of life. So if the patient came in, you'll do the urine analysis. When you do the urine analysis, we can get a blood culture. We'll perform an LP, and there's a weight of the LP, which is there's a risk of trauma, there's a risk of parenteral resistance to it. It needs to be done by someone who's experienced in doing it. And then of course, how to interpret the LP results that you're getting, and then obtaining the inflammatory markers that we talked about, which is the procalcitonin, the CRP. So when looking at inflammatory markers, we have to see that we're talking about procalcitonin more than 0.5 or CRP more than 20. They also mentioned if the A and C in some studies said above 4,000 or in others above 52,000. And then said there is a correlation between having an invasive bacterial infection if there's a fever above 101.3 Fahrenheit, which is 38.5. So you have to consider that within your inflammatory markers. Okay, and then once you do that, think, is there an increased risk of HSV? So how can we measure that risk? So when we said measure that risk, they based it on the mother and on the infant. So when they spoke about the mother, they said, does the mother have a history of genital HSV? Was there any fevers within 48 hours plus or minus of the delivery? If the infant, when he was born, had vesicles, had seizures, had temperature instabilities, how with mouth or mucosal ulcers? Is there any CSF pleocytosis when you did the LP? Is there leukopenia? Is there a severe thrombocytopenia or there's thrombocytopenia? Are there elevation in ALT? So these are considerations to think, is this patient has an increased risk of herpes simplex virus? If yes, send those studies and initiate parenteral treatments, which is acyclovir, and admit to the hospital. If not, initiate parenteral antibiotics, which we'll talk about in the next slide, and then observe for the hospital. Were we able to identify the source or not? If they were able to identify the source and the pathogen, then adjust your treatment to treat the infection. If not, discontinue the antimicrobials that you're having. You can discharge that patient if all cultures are negative within 37 hours and the HSV at 36 hours, and HSV is negative for the PCR. And then manage whatever duration of illness that the patient is having. What are the antibiotics of choices that we can use in this age group, 8 to 21 days? And we'll talk more about why they specified this age group or this antibiotics. It's basically they said, okay, so we know that when we give empirical antibiotics in general, we need to understand that the coverage should at least cover 2 pathogens. And putting that in mind, we need to understand that cephalosporins are not effective against Listeria or enterococcal infections. Therefore, ampicillin would be our number 1 choice. So when we use ampicillin, we give it for that bacteria, or if there's any local community considerations for it. That being said, we know that there's a high rate of E. coli producing extended spectrum beta-lactamase, ESBL infections in the community. And then if we use the empirical regimen, we should include gentamicin because we know that cephalosporins will be resistant. So we can use gentamicin or meropenem. So basically they said, okay, so let's use ampicillin to cover for this enterococcus infections, to cover for Listeria, which is usually 150 milligrams per kilograms per day, and that's divided by 8 days. And then either use gentamicin or ceftazidime. So we're using gentamicin to cover those infections that we mentioned. This sound means that a baby was born in the hospital right now. Or we can use ceftazidime, which is 150 milligrams per kilogram per day, divided every 8 hours. However, if cefotaxime is available, it is preferred, and it's mainly because there's shortage of cefotaxime over the years, so they were going towards ceftazidime, but cefotaxime is a preferred choice. So that being said, the second class that we had was 22 to 28 days of life, and it has to be a well-appearing and no evidence of source of an infection, and temperature is more than 38, yet equal or more than 38 degrees Celsius. So if you see here, we're going to do obtaining a urine analysis, we're going to do a partial sepsis workout. So we didn't do the LP. So complete sepsis workout, we're doing the urine analysis, the UC, the blood cultures, the inflammatory markers, and the lumbar puncture studies. But if we're doing a partial one, we're doing the urine analysis, the blood cultures, and the inflammatory markers. That being said, okay, is it positive urine analysis results? Yes, send the bladder catheterization of the suprapubic urine cultures and go from there. And you can treat, we'll discuss. Or no, but are the inflammatory markers high? So is your CRP above 20? Is your procalcitonin above 0.5? That being said, yes, perform your LP. Because we said here the UA is negative, but you have high inflammatory markers. Let's perform the LP. If we're performing the LP, CSF is obtained, yes. Is there any pleocytosis or is it unable to interpret it? Yes, then you give the antibiotics parenterally. CSF is not obtained, you fail to get the LP, then you give antibiotics and you admit the patients for observation. But no, CSF and everything was fine. Then you go here where you can send them to home for observation. So when we reach this point, let's reach it from the other side. Is there abnormal inflammatory markers? No. Do you want to do an LP? Do you think based on your clinical judgment, do you want to do an LP? Yes, we performed it. CSF was contained. There is pleocytosis or traumatics. Then we go back to giving the antibiotics and admit to hospital. But CSF is not obtained or we decided not to do the LP, you can consider giving the antibiotics and admit to the hospital. So if you can see, these two ends end up in the same way. You admit the patient and you give them the antibiotics if you won't do the lumbar puncture or if you were unable to get the CSF. But if you get it and it's negative and it's not traumatic and it's not CSF pleocytosis, then you have to observe. You can send that patient to observe at home. There's a good way of differentiating between, it's a way that you can differentiate between HSV and traumatic tap, which is basically through the 4 tubes that you extract CSF from. If they're all of them are bloody tap, then you can consider it HSV. If it's lessens and it's more clear as more tubes you fill, then it's most probably a traumatic tap. You don't have to rely on that. It's just an observation thing that you can see and differentiate between a hemorrhagic CSF with herpes simplex or traumatic tap from your manipulation while doing the lumbar puncture. And then, are you going to decide to observe this patient at home or not? Yes, you give them antibiotics, you observe them at home, you send them to the clinic in 24 hours or bring them back to the ED in 24 hours because that's the amount of time your antibiotics will cover that patient for. If not, you give them antibiotics, admit them to the hospital, right? Usually I see is all of these patients get admitted to the hospital. You give them antibiotics and you admit them for 36 hours until the cultures are negative. And then you look here. Did you find a source? You treat it. If you don't find a source, you can discontinue. You follow them for 36 hours and it's the same pathway as we discussed before. So here when we give antibiotics, they usually say, okay, give ceftriaxone IV or intramuscular 50 milligrams per kg per day every 24 hours. And this is the regular dose for ceftriaxone. So you're not aiming for that meningitic dose of 100 milligram per kg per day because you think that patient is well appearing and your CSF did not indicate anything meningitic. And then the last classifications we have is the 29 to 60 days of life. And it's the same criteria that we mentioned. We're doing also partial sepsis workout, which is a urine analysis, blood cultures, and inflammatory markers. Now, is there an increase or no increase in the inflammatory markers? Yes, there's increased inflammatory markers. You send that bladder catheterization or you send that suprapubic cath culture. If it's positive, you treat for it. If you think you need to do an LP based on your clinical judgment, do it. Look at your CSF results. If it's positive, you give the antibiotics. You observe in the hospital. If it's negative and the urine analysis is negative, you can either give parenteral or oral antimicrobials, and you can admit them to the hospital or send them home based on your clinical judgment at this point. And then here it tells you if CSF is not available or unable to be interpreted, you give them antibiotics intravenous and you admit them to the hospital. Or if you think the parents are reliable and you're going to come back, then you return them back in 24 hours. Okay, so no, the inflammatory markers are not elevated. So is there a positive urine analysis? Yes. And you send to urine culture? Yes. Then you don't need to do an LP. You can give oral antibiotics and you can send them home and make sure to follow up within 12 to 24 hours. But if it's no, you don't need to perform an LP. You do not need to administer antibiotics. You can send them home, observe them for 24, 36 hours, which is basically the duration for the blood cultures to come back, and do a close follow-up with their PCP. If you're able to identify a pathogen and the source is identified at 24 to 36 hours, if no, discontinue whatever you're doing, send the patient home, manage the illness. But if you were, make sure, is it limited to the urine? If yes, you complete the treatments of the oral antibiotics, you can discharge the patient home. If no, just treat whatever treatment source that was identified. What was the antibiotic choice? We gave ceftriaxone at this age of 50 milligrams per kg per dose. We also did not give, we can give orals, cephalaxin or cefexime at this dosage, whether it's 50 to 100 milligrams per kg per day divided Q6 hours, or cefexime 8 milligrams per kg per dose every 24 hours. One of the things why they also don't use ceftriaxone, which we mentioned because of the enterococcus infections, the listeria infections, and the E. coli ESBL, but also because in neonates, ceftriaxone can cause that bilirubin conjugation, and they do not like to be, it's not recommended to be used in this age group. So what were the challenges that they faced making these guidelines? And remember, these are guidelines, and a lot of it was based on clinical judgment, clinical experience, and when in doubt, and risk tolerance. So you need to remember, this is the first week of life, what is going to happen, which is the early onset sepsis or the late onset sepsis guidelines that we can discuss. What about serious bacterial infections and the outcomes without stratifications? What about the accuracy predicting of infrequent infections such as meningitis? There's always changes in the bacterial species, depends on the epidemiological graph that you have. Again, it's really subjective assessment based on the clinical appearance. Hence why you can see in the overview that was published in the Peds Review, mentioned well appearing based on attending, and then different work settings and ability to follow up, and you can lose patients to follow up, variable access to neurodiagnostic tools, and families' abilities and reliability of that parents for you to send that patient with them for 24 or 36 hours and make sure that they will follow up or have a good clinical judgment based on your return precautions. And as I mentioned, we talk about risk tolerance. So there's evidence alone never speaks up for itself or convey the truth, because it always requires interpretation. This is a great quote that I read, and it's basically telling you, you're treating the patient. You're not treating only the numbers. It's your history, your physical exam, trusting your instincts, and have to rely on your clinical judgment. Specific consideration that were intended to exclude patients from the algorithm. This is a full circle back from what I mentioned earlier. Remember, they have to be term infants. So preterm infants are not. Those younger than 2 weeks of life with complicated perinatal course are not included. These febrile infants with high suspicion of HSV, you do not have to wait. There's a focal bacterial infection, let's say there's a cellulitis or osteomyelitis. Patients with clinical diagnosis of bronchiolitis, regardless of whether it's RSV or not. These patients are not previously healthy. They have documented or suspected immunocompromised neonatal course complicated by surgery or infection. They have congenital or chromosomal abnormalities. These are medically fragile, which-based infants or chromosomally syndromic patients. Immunization within 48 hours can cause that fever in about 40% of patients. And then infants that may be included of respiratory symptoms not diagnostic for bronchiolitis, a loose stool, but there's negative specimen test, otitis media, current or recurrent antibiotic uses within the past 2 weeks of age. in infants more than 2 weeks of age, positive viral infections in this age group, there's the bacterial rate was lower in viral positive infants compared to viral negative infants. And that was the statistical studies within that age group to discuss what would be a bacterial rate infection when it's positive for infection. And basically, if you have any questions, if you think I explained something, I misunderstood something, this is a platform for all of us to learn together. Let me know. And remember, this is only the first of 4 lecture series about fevers. Next, I'll try to talk about the early onset and the late onset sepsis, the fever without origin, or fever of unknown source, of unknown origin, or fever without source. And then lastly, a topic that is interesting, which is fever phobia. So I hope you benefited. Let me know if there's anything more I can do. And this is based on the guidelines from the 2021 and the Pediatric Review article that was published in 2023. Thank you.